Приглашается следующий докладчик Ярослав Чубак, Варшава, Польша. Ретроверсия вертлужной впадины. Всегда ли необходима передстабулярная остеотомия?
Hello. I would like to thank you first for very kind invitation I received from my friend Professor Rashid Tihilov. We do our best to strengthen a relation between between Polish orthopedics and Russian orthopedics, because we are neighbor countries, so we have to work on that. So, and I got a message, I got a topic. I don't know if you know, I'm a big fan of reconstruction surgery concerning especially osteotomies in the hip. And Rashid asked me to talk about the acetabular retroversion. Is it also always needs for PAO? I try to balance my presentation in contrary to that I said before. So what it is, acetabular retroversion, is it symptomatic femoral acetabular impingement that had a radiographic evidence of acetabular retroversion defined as a crossover sign in AP view, and you can also find it in retroverted acetabula in MRI and or computed tomography. And what we know now, the optimum treatment for the young adults with this symptomatic FAI due to the acetabular retroversion remains unknown or unclear, or there is no so much evidence about that. So retroversion, the retroversion deformity can be associated with volumetrically deficient or sufficient acetabulum based on adequate lateral posterior coverage. Deficient posterior wall coverage you can find and correlated with the progression of osteoarthritis. And the current surgical approaches have included PAO and or open or arthroscopic femoral and acetabular osteochondroplasty. So my preferences is redirectional anteversion producing PAO with or without femoral head neck osteochondroplasty, reducing the prominence of anterior acetabular wall and improving lateral and posterior coverage if deficient. So the other option is osteochondroplasty of the femoral head neck junction and the anterior acetabular rim to reduce the femoral acetabular impingement abutment with the reorientation of the acetabulum using surgical hip dislocation. So the aim of this presentation was to present two groups of patients where we perform redirectional anteversion PAO with a femoral head neck osteochondroplasty, and compare those groups with which we perform osteochondroplasty on the femoral head neck junction using surgical hip dislocation. So there is a retrospective analysis of the group which were operated 2003 and 8. And there were two groups of surgeons and two groups of patients. As I mentioned, there was reverse PAO with osteochondroplasty in 25 hips and osteochondroplasty performed by surgical hip dislocation in 22 hips. The age was almost the same. And we expected similar results in both groups. So this is the examples of different kind of retroversion position. You can find a crossover sign, lateral wall sign, and a prominent sciatic spine. So in all these cases, we have a positive femoral acetabular impingement history of pain, functional limitations, limited range of motion, and inactivities. Positive impingement signs on the during the physical examinations, Then on a radiographic, we see we perform a regular AP and false profile when we try to found this crossover sign, and also there was measure additional angles you see here in the bottom of the slides. The criteria for the treatment was quite clear and sharp. So reverse PAO was performed in acceptable retroversion where the CE angle was below 20 with a positive lateral wall, and osteochondroplasty using surgical hip dislocation were performed in those hips where the CE was more than 20 degrees with a negative lateral wall. This, as you mentioned, today we will have a lecture given by Andriy Korytkin about the principles of PAO. So the PAO is performed by Smith-Peterson approach, anterior approach, but this reverse technique concerns an opposite direction to regular one we use for the dysplastic hip. And classic surgical hip dislocation, it was mentioned before, from the lateral approach with using Smith's nephew devices for osteochondroplasty and rim ergus. So this is one of the examples where we perform PAO. So the results of those two groups shows almost the same amount of points with this Harris hip score. They started on a little bit lower level in the PAO group. Then there was this surgical dislocation group. All hips had combined PAO and with arterial arthrotomy and labral lesion access with osteochondroplasty to reduce head-neck offset. And in this surgical hip dislocation group, all anterior rib debridement when we found the chondromalacia in this degree of outer bridge classification. And this is the final radiometry where you can find lateral central edge angles of Weiberg angle, which is improved in the PAO group very much. And also other angles like sharp angle and anterior Weiberg angle. And then in this group where we perform surgical hip dislocation, there was not such a movement. There was a decrease of LCE and decrease of anterior Weiberg angle, and a little bit increase of acceptable sharp angle. So the complication we found one necrosis of acceptable fragment in this PAO group, and the total hip was needed, and one failure with increased osteoarthritis in the group of surgical hip dislocation, and also total hip was needed. And there was also one failure of hip instability after the trimming in SDH. There was also, what I would like to show you, because we talk about arthroscopy, one failure concerning arthroscopic correction. And there was that group where should be performed PAO instead of performing arthroscopy. So according to discussion, this topic, the acceptable retroversion can be associated with regional under and over coverage. The understanding of the pathomorphology of acceptable retroversion is still evolving, and the appropriate treatment strategy of retroversion is even more primordial state, ranging from the rim trimming to reorientation with limited clinical data to direct one to or either. And acetabular reorientation for retroverted hips has been reported in a limited number of patients. There was an article of a group from Bern. There were 29 hips with crossover scion, 24 which has a posterior wall scion, and all underwent PAO with average follow-up 30 months, with a good and excellent results in 26. And another group of Reynolds described encouraging results in 12 patients treated with PAO, but provided no detailed analysis of the pre-operative and post-operative parameters characterized retroversion in such crossover scion and posterior wall. So Our results also indicate encouraging clinical outcomes with reliable elimination of crossover sign and correction of the positive wall sign in over 90 patients. As shown by the others, I don't know if this data are true, but there was about 30 patients with acetabular dysplasia may presented retroverted acetabula. Those group of AVI with deficit of posterior wall is to perform PAO for reorientation. And that group in our group was also mostly younger, female, and with signs of instability. Opposite to that group, the femoral acetabular impingement with normal lateral or posterior coverage may be treated with osteochondroplasty of anterior acetabular rim and head-neck junction. And that group is characterized by a little bit older male with a normal volumetric value of retroverted acetabula. So the limitation of this study is that they were retrospective, not randomized. The surgical decision-making process evolved over the time, and the clinical and radiographic follow-up was not long enough. Our study did not include arthroscopy in the treatment, so that's what I show. Arthroscopic osteochondroplasty could be used as an alternative, I think, to surgical dislocation while allowing the same principles to direct surgical dislocation decision-making. So in conclusion, we can conclude that this decision regarding the best surgical management of the patient with femoral acetabular impingement associated with retroversion remains difficult and depends on the thorough consideration on the hip 3D morphology and the degree of article cartilage damage, so osteoarthritis. Thank you very much for your attention.